Good evening, everyone, and welcome to our December Town Hall. And our program this evening is on the pharmacist's role in the management of diabetes, and specifically talking about continuous glucose monitoring, or CGM. And we have two presenters this evening. We have Dr. Lalita Prasad Reddy and Dr. Alvin Godina, and I'm going to turn it over to Lalita, and she'll take us through tonight's program.
Thank you so much, Garth, and thank you for inviting us and having myself and Alvin here to discuss a little bit about the pharmacist's role in the management of diabetes, specifically focusing on the use of continuous glucose monitoring. And just to give you both a little bit of, everyone a little bit of background, myself and Alvin are colleagues at Rush University Medical Center in the internal medicine clinic. And in that clinic, we share the role of running a pharmacotherapy clinic where we manage patients with diabetes. And really in the last year, our involvement with getting patients on continuous glucose management and self-managing them has really taken off. So we're here today to talk about why it's important to understand CGM, how it can benefit your patients, and how we as pharmacists can use the information from CGM to guide our treatment decisions for patients. So in order to think about why does CGM offer us a potential advantage over traditional models of glycemic monitoring, it's important to think about the hemoglobin A1C, self-monitoring of blood glucose, and then we can compare that to continuous glucose monitoring. So as everyone knows, the hemoglobin A1C is a measurement of 3 to 4 months of glycemic control. In the vast majority of patients, it's going to be a measurement of about 90 to 100 days. But the problem is there's wide interpatient variability. And a lot of that comes from the fact that certain conditions and medications can affect the A1C. So specifically, medications that change either the lifespan or the oxygen carrying capacity of the red blood cells. So sickle cell anemias, severe iron deficiency anemias, thalassemias can all affect the A1C and make it a little bit more difficult to look at long-term glucose control. There is rising data that there could be potential differences between ethnic populations. And the problem with the A1C is it provides limited insight into glucose variability. So we do know that if a patient has an A1C of less than 7, then we would consider them controlled, but we don't know what drives that A1C. Is it controlled blood sugars in the first thing in the morning, but later in the day they're uncontrolled? Is it that they're controlled after meals, but before meals, but postprandially they're uncontrolled? It really doesn't give us a really strong look at what's going on throughout the day. Self-monitoring of blood glucose provides us the benefit that it provides the patient as well as the provider a real-time reading. It lets us look in and find the insight of what is that blood sugar in response to food, in response to activity. But as you know, self-monitoring of blood glucose is really dependent on a patient's involvement in diabetes self-management. The problem when you look at self-monitoring of blood glucose and previous methods of glucose control and glycemic monitoring is you're really just looking at a single point in time. So I turn back to this chart to just have you look at this correlation of the A1C with the self-monitoring of glucose. So the self-monitoring of glucose are these isolated square dots, and this is certain periods and points in times where patients would just randomly check their blood sugar, and then based on that we would be able to somewhat estimate the A1C. The benefit of continuous glucose monitoring is you can see that this patient had a reading of 145 earlier in the day, later in the day went to 165, but we don't know what happened in between that time. So the benefit of continuous glucose monitoring is it provides real-time readings in a pulsating fashion. And it can inform patients and providers about daily patterns, provides a very comprehensive assessment of blood glucose control because it gives those pulsating readings almost every 5 minutes. It can also really provide insight to our patients because it can alert patients to warnings, both if their blood sugar is rapidly dropping or if it's rapidly escalating, and allows for a more proactive approach to take control of, preventing that hypoglycemia from getting worse or preventing that hyperglycemia from elevating further. When it's used appropriately, it appears to correlate to hemoglobin A1C pretty well, and it can beneficially inform patients with real-time feedback. So one of the things that our patients talk about a lot is the benefit that they get their glucose readings right before they eat, right after they eat, with minimal invasiveness to them. They don't have to prick their fingers, they simply can scan, or it's automatically sent to the receiver, and they can make those better informed decisions without having to change their daily activities and without having to put much thought into it. So continuous glucose monitoring, with it, a small sensor is placed under the skin, and this measures the interstitial glucose levels in intervals of 5 to 15 minutes. Our newer products measure them closer to every 5 minutes, so you get almost 200 readings a day, which this provides a more comprehensive assessment of glycemic control. Now, newer models of CGM, all CGM and all interstitial glucose readings are going to lag capillary readings by a little bit, 5 to 15 minutes. Our newer CGM models will have that lag time has decreased. So we can only expect about a 5-minute difference between capillary and interstitial glucose. And as we had mentioned, the benefits to this is that they can be utilized to make real-time decisions with minimal intrusion to the patient. Now, we're really starting to kind of move away from using frequent professional CGMs. We still use them in practice, but now it's becoming much easier to use continuous glucose monitors on a personal scale. And so patients, as you know, are being dispensed these more frequently and more readily, and insurance companies are more willing to provide insurance coverage for them because we do know that they do oftentimes align with better improved glycemic control. So who are the patients that are indicated for CGM? So this is interesting because the professional society guidelines differ a little bit to the individuals that would benefit. Now, we know that pretty much anybody with diabetes, whether it's type 1 or type 2, would likely get a beneficial effect from being able to have real-time feedback in 5-minute increments and be able to make informed decision based on that. The International Consensus of Diabetes states that all patients with type 1 diabetes and all patients with type 2 diabetes treated with intensive insulin therapy are candidates for CGM, as well as individuals with problematic hypoglycemia. So typically we're thinking about individuals that may have hypoglycemia unawareness. Per the American Diabetes Association, they consider CGM to be indicated in individuals not meeting glycemic controls, certainly in type 1, but you can theoretically consider it in type 2 as well. They further recommend it for individuals that have hypoglycemia unawareness, who are on sensor-augmented pump, and in pregnant patients. Now, the American Association of Clinical Endocrinologists is pretty actually aggressive with the patients that they want it on. So they state that anyone with hypoglycemia and type 1 diabetes with unawareness or is not meeting goals should be considered, and any patients with type 2 diabetes on intensive insulin therapy with a high risk of hypoglycemia or hypoglycemia unawareness should be considered. So really the ACE recommendations are the broadest and provide the CGM recommendation for the most comprehensive set of patients. So what are some benefits and challenges of CGM? Certainly, we do know that the benefits of CGM is that patients will have improved glycemic control, and we'll talk through some studies that show that A1C and glycemic control was improved in patients who frequently utilized and looked at their CGM for feedback. We certainly know that it improves self-management skills for patients' diabetes. Overall, it does suggest, some studies suggest that it improves quality of life. Certainly, a limitation of self-monitoring of blood glucose, especially in patients that are indicated to test 3+ times a day if you're on intensive insulin therapy, that can be pretty intrusive to daily living. So this is reducing those limitations of a patient pricking their finger and checking their capillary blood sugar, because they just get the reading automatically as it's sent to the sensor, or it's sent automatically through a scanner. And as we've mentioned multiple times, it provides for informed decision making. Now, there is a downside to anything, and so obviously there's the personal frustrations. It takes time to learn a CGM. It takes time to learn how to use all that, and there can be dangers to too much information. So CGMs, as I mentioned, can give up to 240 readings per day, which can be very informing, but there is a dark side of being very informed at all times. Site concerns with some of the sensors, technology constraints, because the CGM oftentimes interfaces with iPhones or Androids and provides systems to provide your practitioner or yourself a more comprehensive view of the last 14 days. Some agents or some sensors will need calibration. Patients get data and alert fatigued. There's learning challenges associated with it and decision fatigue. So again, there can be an overabundance of information, and sometimes that can be very frustrating. Now, certainly what we see in our clinic setting is that our healthcare providers really want to start prescribing CGM because they know that it's very beneficial to our patients. However, we certainly also recognize that there's a lot of challenges for them because there's a lot to learn. There's a lot of different systems. Every system operates a little bit differently, and not everyone knows how to utilize the information and data available to interpret glycemic control and make therapeutic decisions based on it. So currently there's different CGM products available. The ones that you will see most out in practice are going to be the Freestyle, Libre, Dexcom, and Medtronic. And you can see here, they vary in certain ways. Probably Freestyle, Libre, and Dexcom are the ones that are dispensed most frequently right now. The benefit of those agents is that they replace self-monitoring of blood glucose. So patients don't have to also confirm a reading of hyperglycemia with a self-monitoring check. Whereas Medtronic and Eversense requires that finger stick confirmation or calibration occurs multiple times a day. Eversense is something that is starting to be coming to the market a little bit more, but because it has a 90-day wear, so it provides a little bit more of monitoring ability because individuals don't have to change their sensor every 7, 10, or 14 days like you need to do for Medtronic, Dexcom, and Freestyle. The challenge with Eversense, however, is that it needs to be administered and applied and inserted within a physician's office. So you can see here the differences between the agents from a clinical practice. I really like the agents that have longer wear. I really like the CGMs that provide that our patients don't have to change the sensors as frequently. I obviously want to counsel my patients that the benefit of wearing this is that they don't have to self-monitor. And so really that's something that's often a pro that I'm going to think about with the agents I choose and recommend. And then there's also things to think about because some of these CGMs have a transmitter that is separate from the sensor, whereas some CGMs have the transmitter integrated into the sensor. So it's just fewer pieces that the patient has to wear and take care of. So now let's just look into some trials and some cases for CGM. Okay, so this was a trial done in 2017, and it looked at the effectiveness of CGM in adults with type 1 diabetes treated with insulin injections. It was a randomized clinical trial of 158 patients with type 1 diabetes, obviously on multi-daily dose insulin therapy, with A1Cs of 7.5 to 9.9%. So the primary objective was the difference in change in A1C from baseline to 24 weeks. So the individuals almost wore the CGM for a period of 6 months. So after this 24-week period, the mean A1C reduction in patients that wore the CGM versus those that did not had a statistically significant reduction in A1C. So you can see that the patients within the CGM group dropped their A1C by 0.6%, whereas the patients in the other group did as well, but this is statistically significant. CGM use was associated with a high degree of improved patient satisfaction, increased time and range, with my colleague Alvin will talk about in a little bit, decreased time with periods of hypoglycemia, and decreased glycemic variability. So obviously, when we're talking about decreased glycemic variability, we're obviously aiming for a certain range. And as Alvin will talk about, that range in the vast majority of patients is going to be 70 to 180. However, if we have patients that are going from 70 to 180 back to 70, 180, 70 to 180, they're still within range, but there's too much glycemic variation. And we want to minimize the amount that patients are going up and down and having labile blood sugars. So you can see here, this was the stats from the Diamond trial. And again, showing that patients that wore the CGM had statistically significantly less glucose variability, less hypoglycemia, and better A1C control compared to individuals in the control group. There was another study that was more recently done looking at the case for CGM in patients with type 2 diabetes on basal insulin. So it's pretty well documented again that CGM use is effective for patients with type 1, but really now we're starting to think about it more with type 2 patients. So the objective of this study was to determine the effectiveness of CGM in adults with type 2 diabetes treated with insulin in primary care practices. And they randomized 175 adults with type 2 diabetes with basal insulin with or without background oral therapies, but patients were not on prandial types of insulin. And similar to the previous study, the primary outcome here was looking at the A1C reduction in 8 months. So here you had a mean A1C reduction from 9.1 to 8 in the CGM group and only 9 to 8.4 in the blood glucose monitoring group. So again, a statistically significant reduction. CGM usage in patients with type 2 diabetes was associated with improved glycemic monitoring, reduced glycemic variability, and resulted in significantly lower rates of hypoglycemia. So similar to the patients that we saw in the type 1 study, individuals that are treated with insulin and are living with type 2 diabetes are also candidates for therapy. And so here again, you have the trial outcomes here, but most importantly is that there was a statistically significant reduction in A1C, a reduction in hypoglycemia rates, and a reduction in glycemic variability, again, showing that the informed decision-making really could help patients and prevent that glycemic excursions from occurring. So at this time, I'm going to go ahead and turn it over to Alvin, who, now that we've talked about the background and foundation of CGM, he's really going to focus on the interpretation and use of CGM in practice.
All right, great, thank you. So exactly that. So from here on out till the rest of the end of the presentation, we'll be discussing the ambulatory glucose profile. So giving you an example here to look at, discussing the components, reviewing the terminology, and then looking at the data and the outcomes that the summary provides you, and then how that benefits us as providers utilizing this, and then patients in terms of the outcomes associated with improved glucose outcomes. So next slide. So here's an example of that summary. So this contains a couple different components. There's a lot of different numbers and a couple different charts here to look at. So, upon first glance, it's kind of like, where do I look first, right? So you kind of just work your way through this. So you do have your glucose statistics and targets. So upper left corner of the summary, it's going to be giving you what your goals are for the patient, specifically for them, and then also what their values are for the period of time that they've been wearing the sensor. And then next to that, on the upper right, you have time and range, which is broken down by how much time is spent in high ranges or low ranges or in target range. And then you have your actual ambulatory glucose profile. So this big chart, which has a couple different colors, which delineate a couple different aspects of the patient's data. So I'm just kind of breaking this down. We have the solid black line, which shows the median glucose for that patient over the period of time that they've been wearing that sensor, specific to that time of day. So regardless of what the day is that it is of like the 7, 10, or 14-day period that they're wearing the sensor for. You have the green lines, which delineate the upper and lower bounds of the target range for that patient that's been set. And then also you have a darker blue shaded panel, which shows where 50% of the glucose readings lie for the patients, and then the lighter blue shading, which is where 90% of the readings lie for that patient within that time frame or that time of day. And then you have some, it's kind of hard to see here, but some dotted lines, which are a little faint, but those represent the upper 5 and lower 5% of the readings for that patient. So anything above the line is going to be the highest 5% of readings. And then anything below that gray line is going to be the lowest 5% of readings. And then the last portion of the summary here is going to be the patient's daily glucose reading. So a chart specific to the measurements that they had for the day. And so all of this is going to be kind of variable based on which device the patient is utilizing. So if they have a flash sensor, it depends on how many times they're testing per day, how many times they're actually scanning their sensor. And then if they have a continuous reader, so like a real-time device, it's going to be continuous. So you're going to get readings based on however frequent the device records. So next slide. So then with all of that, all that data, what do you do with it? How do you interpret it? So you kind of want to just work your way through it also. So checking firstly to see if you have an adequate amount of time that's been captured for the patient, enough data. So the lower bound is typically 70% of the CGM time that's been worn being active. So just because a patient has the sensor placed in them, whether it be in their arm or their belly, it might not be connected properly, or it might have not been started, or it's not transmitting the data to the receiver. So you want to make sure that the report that you had has at least 70% active wear time. And then with that, you should have adequate number of readings to then be able to feel comfortable with that data to then interpret it and kind of make changes if necessary based on the data that you have presented to you. And then you want to take that report and then they use the phrase kind of mark it up. So essentially look to see, where there's information that you need with regard to the medications that the patient is taking. So if it's a patient who's injecting insulin, which insulins are they taking? What times do they inject? What's the dosage of those insulins? And then relative to what you're seeing on the chart. So that way you can kind of start piecing together the whole picture, getting the patient's perspective and subjective information. So, is there a time of day where they're, low or high? And then, what might be contributing to those trends that we're seeing in the graph. So trying to get their take on what the actual chart looks like, and then evaluating for high trends or low trends, and then also looking to see if there's periods of time in the day where there's variability in what the results look like. So, if at 6 a.m. they have lows, but they also have highs, like what's going on in that scenario. So like why there's sometimes periods when their number is low, and why there are times at the same time of day that their number might be high. And then if you have previous data, comparing this summary to a previous report as well, that'll be beneficial because it'll help you identify if there's been any changes, and that too can kind of help you guide your questioning your interview of the patient. And then once you identify all of those and come up with a plan that works and that you're agreeable with the patient, document all that, implement the plan, and then upload this to the patient's EMR. And so just kind of as an aside, with regard to utilizing these devices, if you're specifically billing for the use of the device, it's actually required that you upload the summary, so like this AGP report, into the patient's EMR so that you can bill appropriately for that time spent and the encounter that you're having with the patient to interpret this data. Next slide. So here is just a list of different terms that you'll see whenever you're interpreting an AGP report, so at ambulatory glucose summary. And so the hope is that, given the fact that there's multiple different products available to patients at the moment, that we try to standardize the terminology and the goals that are set for the patient, so that regardless of the device that's being utilized, we have a similar understanding of what these numbers mean and how to interpret them and how to apply them to the patient's care. So number of days worn is essentially like how long they actually had it on in the period of time that the sensor is wearable. So if it's the freestyle that has 14 days, how many days out of the 14 was it active? And then percent time that's active, so that'll give you that percentage. So it might not be, based on day to day, but it might be that, maybe on day one it wasn't active yet because it wasn't connected to the patient's reader or phone, but then, halfway through the day, they got that taken care of. So it'll look more so at the percentage of time versus like the number of days that the patient had it on. The mean glucose, which is in the upper left of that report, and then also given to you as a median, as a dark black line in the reports. Your GMI, which is a term that's utilized now, but used to be called the estimated A1C, so to speak. So it gives you an idea of kind of what the patient's control is based on the data that you have. So if the patient's wearing the sensor for 14 days and the report has that data, what the patient's A1C would look like if that data was then extrapolated beyond that 14-day period. Then you have glucose variability, which gives you a sense of like how variable the glucose numbers are in a certain period of time throughout the day. And we have a target of trying to keep that less than 36%. And then the last couple terms there are just essentially what the target ranges are for patients based on milligrams per deciliter. So we have, very high, in range, low, and then very low. And so you'll see that also reflected in the next couple slides. So one of the most important measures that we have for patients with regard to use of CGM is the time in range. And so the reason for this being important kind of goes back to what Dr. Reddy was speaking about earlier in her portion of the presentation, where you might have a patient who has an A1C that would be 7, but it might not necessarily reflect if they have periods of being low or periods of being high. And so the time in range gives us a sense of kind of what those numbers look like. So how much time the patient is actually spending within different glucose ranges. And so based on different patient presentations, so these are 4 examples of a patient who's a type 1 or a type 2, a type 1 or a type 2 who's at higher risk or an older patient, and then pregnant patients based on kind of what their presentation of diabetes is as well. They'll have different goal proportions of time in range. So for a type 1 or type 2, you would hope that they spend more than 70% of their time between 70 to 180 milligrams per deciliter, less than 25% of the time greater than 180, but less than 250, and then less than 5% over 250. And then on the opposite spectrum, less than 4% below 70, but greater than 54, and then less than 1% below 54 milligrams per deciliter. And so you can kind of individualize that based on the patient's presentation and then what risk factors you find for them, based to then guide you as to what the proportion of time should be set as a goal for the patient in terms of their time in range. Next slide. So then interpreting that, so what you're looking for or hoping for is that the target range is the most expansive, that it's consuming the most time that the patient is wearing the reader or sensor, should I say. So kind of the mnemonic being more green, less red, because you're seeing less of the time outside of the ranges, so either being high or being low, and then also looking for a flat, narrow, in range trend with regard to your HEP report also. So the reason for that being that would indicate that the patient is within goal, so within the green lines, which are your set target for high and low, and then also having a low amount of variability. So not having a GV or glucose variability of greater than 36. Next slide. Which is essentially what this slide here is kind of alluding to as well. So if we can see kind of closer to 6 a.m., you have a little bit of a tighter, or should I say maybe around like 7 a.m., you have a bit tighter window than you do around like 3 to 6 p.m. where at some occasions throughout the wear of the sensor, the patient has readings of like 180, but they also have readings of being greater than 350. So at that time of day, during the time that the patient was wearing a sensor, there's a greater amount of variability in the patient's glucose versus earlier in the morning. And so the beauty of that is that you're able to identify parts of the day that the patient is having a little bit harder time controlling the glucose, and you can tailor your approach in terms of care to those times of day. And you can also, target your questioning to try to identify what's going on there to then help the patient improve their glycemic control in those specific times that they're struggling with. And so, we've spent the last couple slides talking about time in range. And so the reason that we care about it so much is because it does correlate to an A1C. So multiple studies have now shown that the higher the time in range, the better the A1C. So with a standard being that we're shooting for a time in range of at least 70%, because that correlates to an A1C of about 7. And there is a kind of a range for that. So 95% confidence interval being between 5.6 and 8.3. So, and I can tell you from experience in practice, I have seen patients who have, a time in target range of, in the 80s and a GMI of about like 7.2. But then when they had an A1C checked, it was in the 8s. So, there's a little bit of variability there, but it's pretty, there is a pretty strong correlation for a majority of patients. So this is a really good indicator of the patient's control. So that's why we appreciate and rely on the time in range to guide us in terms of how well the patient is doing in the interim between A1C measures. The next slide. And so then more importantly, with regard to the outcomes that the patient would probably care about are the complications associated with prolonged uncontrolled diabetes. So time in range is also being correlated with having less frequency of complications associated with uncontrolled glucose. So for both retinopathy and microalbuminuria, we see that when patients start approaching 50, 60, 70% time in range, the likelihood of them having these complications diminishes significantly. So it is a pretty important measure. And so we can use that to guide us in terms of, what's happening with the patient in between those A1C measurements so that we can make more adjustments more frequently if necessary, because as we all know that the longer they spend out of range, the more likely to kind of incur these complications. And so the last measure here to take note of is the glucose management indicator, or GMI, which I kind of previously touched on. So kind of a surrogate or an estimate of the A1C for the period of time that the patient is wearing the sensor. So the nice thing about this is that, patients might have some trouble with the sensors from time to time. So it might fall off, it might not, connect, or it might lose connectivity at some point in time during the wear. But so long as they have a couple, the lower bound being about 10 days of data, it can give us a GMI. And so the nice thing about that is that it gives us an idea of, how well the patient's controlled, even though we don't have a whole lot of data. So this kind of correlates back to patient population data. So like if a patient has an estimated glucose of 150, we're pretty confident that the A1C would relate to be about 7 based on comparison to a greater population with a similar estimated average glucose. So that's the benefit of looking at that. So you have an idea of how well the patient's controlled, even though you haven't done an A1C for some period of time. And then even without perfect data, you're still able to get trends with regard to hypoglycemia and then also glucose variability. And so the other benefit is, also touching back to what Dr. Reddy described on that chart earlier in this presentation, is that it gives you a better sense of like what's actually going on with your patient specifically. So, the A1C is giving you an idea of their control as a whole over the period of 3 months, but not necessarily telling you what's going on behind the scenes. So the GMI is helpful in being able to give you a better sense of that. And then also in tandem with like the glucose variability, you get a sense of like if the patient is truly controlled, or, do they have periods where they're experiencing, trends in hypo or hyperglycemia, which is just kind of a wash in terms of the A1C where you don't see it. So it's useful in terms of getting all that extra information. Next slide. And so kind of leading into this slide as well. So the variability is useful to have. And so there's a couple different ways to measure that. So throughout that AGP report, we see that we get measures of glucose in terms of median or mean. But that in itself is not useful entirely without knowing kind of what the whole picture looks like. And so that's where the glucose variability comes into play. So once you have all that extra data, you get a sense of kind of what that mean and median really mean. So, you'll get a sense of like how much or how many of those data points are within a specific range. And so the tighter that is, the better the control for the patient. And so, although there's a couple different ways of looking at this, the best measure for that has been the coefficient of variability, which is what you'll see on the AGP reports, in that as we mentioned beforehand, has a goal of being less than 36 for to consider the patient controlled. So if we see a number greater than that, it's hard to say, the patient's numbers are consistent. And so there should be some more digging into what's going on behind the scenes with the patient to try to get those numbers to be more consistently within range. Next slide. And so with everything that we've said, I think this technology encompasses a lot of different aspects of pharmacy and patient care in general. And so there's a couple different ways that pharmacists can get involved in being able to get a patient to implement the technology and use it to improve their control. And so I would say that Dr. Reddy and I both probably go from start to finish in terms of this list with regard to implementing these different aspects of being involved in CGM for patients. So the first thing being trying to ensure access. So once the patient's able to actually obtain the technology, being sure that they are then able to implement it and understand kind of what is required of them to be successful with using the devices that they have in place. So, and then beyond that, also making sure that they have all the information that they need to implement the technology over a long period of time, or whatever period of time that you're hoping to utilize it to improve their control. So if you have a patient who is interested but then doesn't really implement it, it's not of much use because it won't really provide you the data that you're looking for. So you want to make sure that the patients have all this information, that they feel comfortable that they be able to utilize it so that you can actually optimize the technology in the way that we hope to do. And then once you do have that data, interpret it so that you can then make adjustments as necessary. So I think we both have done that and found that this technology has been vastly useful in terms of being able to improve control. And I think even without our intervention, sometimes patients just take advantage of having that constant feedback to then educate themselves, right? It's like, hey, if I eat this, this is what happens to my blood glucose. So then, instead of us telling them, hey, avoid these things, or like watch your portion size of this, they see it for themselves and they kind of guide themselves to make better decisions. So all that kind of in a nutshell is the benefit and kind of ways that we get involved with the use of the technology for the patient. So then with that, we'll take any questions that you may have.
My God, it's so good. I had to put my camera on. You guys, this was awesome. We should have this in the advanced practice training. So this was, I hope there's more intricate questions if you're not familiar. This is the future. We are not going to go back, and as pharmacists, we understand this technology probably better because we are early adapters of all technology. So, so thank you very much. You two did awesome. So proud, so proud. Thank you, thank you, thank you.
Thanks, Darlene.
Thank
Tom,
you.
I see
Yeah.
that you have your hand raised. If you want to go ahead and unmute.
Yeah, can you hear me?
Yes, we
Yes.
can.
Can you hear me?
Yes, we can, Tom. Go
Okay,
ahead.
so a lot of diabetics end up with chronic kidney disease, and a lot of patients with chronic kidney disease end up with anemia. So is the GMI a better tool to use versus A1C in those patients?
It is. It's more representative because keep in mind that the GMI isn't reflective of the concentration of glucose on red blood cells. And
Yeah, so you could use it. It'd be better to use it then than an A1C for sure then.
absolutely. And I think that's one of the limitations is for patients with really severe chronic kidney disease or anemia of CKD, and we're talking about hemoglobins of 6 or 7, or in individuals with sickle cell disease or other beta thalassemias, there's limited use of tests for long-term glycemic control. We previously could use fructosamine, but fructosamine is just not available everywhere to get to utilize as a measure. So certainly it's much more beneficial because it's not subject to diseases or changes in the red blood cell structure.
Okay, I had one other question. On Medicare coverage, from the patient's perspective, do you know how these are covered? I mean, I know you have to be on 4 times a day insulin, but what are the co-pays and what's this going to actually cost them if they're on Medicare?
That's a good
Alvin, do you want to
question.
take that?
Yeah, absolutely. So it's a good question. So I would say most patients fall into 3 buckets when it comes to coverage. It's either going to be Medicare, Medicaid, or commercial pay, or I guess like out of pocket if you want to consider a 4th one. When it comes to Medicare, I would say most payers are going to follow what Medicare mandates. And so, as you mentioned, it does have a minimum insulin requirements. And so that currently is actually 3+. So as long as the patient is injecting 3 times a day, GLPs don't count. So it has to be insulin. And the previous requirement of having at least like 4 times a day SMBG has also gone away too. So it's not as restrictive as it used to be. And if it is covered by Medicare, it's essentially covered in totality. So the patient would be provided their reader for whatever device, and then also the sensors as needed based on whatever the frequency of placing them would be. So if it's 7, 10, or 14 days. With regard to, and I guess like the other thing to keep in mind too is that depending on the payer, if it's Medicare or Medicaid, they do have preference as to which device. So it's just based on whatever the formulary is. So most Medicare will do both. Like for example, we commonly see like Freestyle and Dexcom. Some Medicare or Medicaid plans, should I say, in the state of Illinois, only will do Dexcom. But these things are changing actually very rapidly. I actually was in touch with a representative from one of the companies today, and they previously were not covered by Medicaid, but they are now as of today. So this is a very kind of fluid situation, and we are seeing it more and more. So I think more payers are starting to pay attention to the data. So things do change, and it seems to be becoming a little bit easier for patients to get these covered. With regard to copay, if it is a self-pay patient, if they just want the technology, for example, they can do that. So most devices are pretty expensive if you're going to pay for out of pocket. The one that is relatively cost efficient is Freestyle, and that the copay ends up being, I guess, like the copay ends up being about $70 for 2 sensors, which is a month supply, and usually no more than that. So it can be, a barrier for some patients. So it's just something to keep in mind for those that you're prescribing this to.
Okay. All right. Thank you.
Thank you, Tom. Harry, you have a question? Go right ahead.
Yeah, just to follow up on the last comment about billing Medicare. There is the possibility of getting it through Medicare. The pharmacy side on the dispensing, there is a MAC that they pay for a combined claim for the transmitter, the sensor, and any other supplies, including any of the additional like finger prick testing supplies. But the MAC on it doesn't necessarily cover every single item on the market. And so my recommendation is, if you're looking for patients who are going for Medicare, is to, I'm not going to say one company or another, but I would at least encourage you to be aware that Medicare only accepts one specific billing for anything CGM related. And you really need to be mindful of what those costs associated with that billing can end up being. So just kind of throwing that out there on the dispensing side, that it's something to be mindful of.
Thank you, Harry. Sam, you had your hand up.
Really good presentation. I appreciated it a lot. Quick question. So when you're dispensing test strips under Medicare, they have all these requirements for like patient logs and such. Are there similar requirements for record keeping when it comes to dispensing CGMs to patients on Medicare?
Alvin, do you want to take that? Or do you want me to?
So with regard to dispensing, I'm not entirely familiar with, if there's anything that's required on the pharmacy end. I mean, on the opposite end of the spectrum from with regard to like ordering the supplies or submitting the order to a DME, they do have specific requirements. Not sure if that exactly answers your question, but at least on our end of things, they do want to see some notes. Oftentimes it's required to show the request, right? So like a note that documents that the patient is on, whatever number of doses of insulin that they were previously testing, X number of times per day, or if the patient falls outside of that, if it's for Medicare specifically, some sort of rationale as to why you're asking for it to be covered if the patient doesn't fall within that criteria that they preset. So at least from our side of things, there are some requirements in terms of documentation, so they'll ask for that, and it has to be periodically done. So I would assume that on a yearly basis, being Medicare. But from the pharmacy perspective side of things, I'm not entirely familiar with if there's any specific record keeping that's necessary.
If I may add, I actually haven't been able to find a local pharmacy that is able to dispense CGMs under Medicare Part B. What I've had to do is contact like one of the DME suppliers that is specifically contracted with Medicare and have them deliver it to the patients. And I think my impression is at least that they maintain just the records that are submitted when the initial approval is requested through Medicare. So they'll ask for all the things that Alvin just talked about.
Okay. Dennis, I see that you're unmuted. Did you have a comment or question?
No, I'm browsing.
Okay, you're
Sorry.
good. Any other questions or comments? All right. Well, thank you, everyone. I'm going to put the evaluation link here in the chat, and then I want to stop the recording so we can give the code.